At this time, I'd like to call forward House Bill 289 for its first hearing, sponsored testimony. This morning we have Representatives Michele Grimm and Tristan Rader. Welcome to committee. The floor is yours.
Thank you. Chair Lampton, Vice Chair Craig, Ranking Member Hall, and members of the House Insurance Committee, thank you so much for the opportunity to provide testimony alongside with my joint sponsor, Representative Rader, on House Bill 289. My joint sponsor will be laying out more specific details, but I'll be talking about the quality of life outcomes right now under our current system. Across Ohio, regardless of its district we represent, is urban, suburban, or rural, it is hard to deny that Ohioans are struggling under healthcare costs. I know this because of my previous role as an at-large member of Toledo City Council, where I led the effort to abolish hundreds of millions of dollars in medical debt for Lucas County residents, and also because of my previous experience in public health working in community clinics. According to an economic impact study performed by Span Ohio, on average 20,000 Ohioans apply for bankruptcy due to healthcare costs every year. Every day, Ohioans are putting in the impossible scenario of deciding between physical or financial well-being. Many would look at these statistics and argue that these can only be cases of people with no coverage only choosing to live a life of in a reckless manner. This is simply not the case. According to a recent study from the Health Policy Institute of Ohio, 26% of Ohioans on employer-sponsored health insurance still struggle to pay their medical bills. Under our current system, we are carrying the cost not for actual medical care, but often for supportive, administrative, and insurance costs. These costs are ballooning more and more year after year. According to the same economic impact study, 15% of insurance premiums go to redundant billing, overhead, profit, advertising, marketing, and CEO salaries. None of these provide health care or increase quality of life for Ohioans. Looking to the future of the Ohio Healthcare Plan, costs will be controlled by simplifying the billing system, establishing budgets, and negotiating the bulk purchasing of pharmaceutical drugs, as well as by other methods. It is expected that with streamlining administration functions and billing procedures, the plan will result in an estimated $11.6 billion or more in savings. Administrative functions eat nearly 1/3 of every healthcare dollar spent in this country. According to the Kaiser Family Foundation, Ohio businesses and residents paid more than $124 billion annually for all privately and publicly funded personal healthcare services and products. These products include hospital care, physician services, nursing home care, and prescription drugs. The Ohio Healthcare Plan will not increase that amount. In fact, it seeks to reduce that cost by more than $11 billion annually through the administrative savings. Of the $122 billion in annual healthcare costs, more than $61 billion was for Medicaid and Medicare. Private funding from health insurance companies make up roughly the remaining portion. It is the amount we would be paying in a single-payer system, except that we do expect to save drastically on overhead and administrative costs. Chair Lampton, Vice Chair Craig, Ranking Member Hall, and members of the House Insurance Committee, thank you so much for the opportunity, and I'm going to pass it along to my joint sponsor, Representative Rader.
Thank you so much, Representative Grimm, and thank you to the members of the House Insurance Committee for hearing this today. We greatly appreciate this opportunity. So let's go into some of the details of this bill. So the universal coverage would cover all Ohioans, regardless of income, age, or ability. It would have no co-pays, deductibles, or premiums for anybody. The coverage would be comprehensive, including medical, health, dental, vision, prescription, and emergency care, and more. Out-of-state emergency care would be included, and reimbursement setup would be dictated by the Board of Health, which would set up, the Ohio Health Care Board, rather. So the system would be a single payer, meaning one insurer that would pay all these bills, or a sole payer is another way to say it, and the Ohio Healthcare Agency, governed by the Ohio Healthcare Board, would be set up or stood up to administrate that. The board would be comprised of 15 members from all over the state of Ohio. In fact, there'd be 7 regions created. From those regions, there'd be 2 members from each region, and then the director of health here at the state would be the chair of that board. Administration would be set up with an executive director and other individuals to oversee the program. It's a comprehensive budgeting system would be included. It would include system operations, provide all reimbursements, capital investments is included, drug equipment purchasing, research, innovation are all included in that budget that would then have to be reported to the House every single year. So there is some accountability built into this as well. Cost caps. Administrative costs would be capped at 5%. You heard that the private healthcare industry has pretty high administrative costs. In fact, I did a little bit of Googling too. United Healthcare has about 13%, and they're one of the more efficient companies out there providing healthcare to individuals. This would cap administrative costs at 5%. I think it would actually come in at lower because Medicare runs at about a 2%, 2 to 3% administrative costs. Pretty efficient program. So we're talking about a very efficient program here. It requires performance monitoring and reports to the General Assembly and independent review boards. So funding sources, here's the meat and potatoes of it. In order to pay for all of this, what we would be proposing here is up to a 3.85% payroll tax, gross receipts tax of up to 3%, and an income tax on high income earners of around 5% for those that make 200%. $200,000 or more, and then 6.2% on incomes that exceed the Social Security cap. I believe the Social Security cap right now is $168,500. So basically, if you make less than $168,500, you wouldn't see an increase. So that's 91% of Ohioans would not see an increase in their income. And if you make, say, $200,000, I did a little bit of math before this, you pay a little less than $2,000 extra dollars per year, which I think is a lot less than whatever you're paying for your insurance, especially if you have a family, right? So the majority of Ohioans, the vast majority of Ohioans, will not see a tax increase. And for businesses, too, I might add that a payroll tax increase of 3.8%, I think comes in at a lot lower if you're not having to pay those healthcare costs. Because right now in the state of Ohio, at least the companies I looked at, the Fortune 500, the bigger companies that are reporting, show about a third of their employee costs are insurance or benefits. The whole benefits package come in around a third of the employee costs. So this would greatly reduce that third. We can get rid of it because you include more in that third, of course, than just insurance. So workforce protections, we do understand that this will cause some shifts in the workforce, right? If we're actually going and saying that there's going to be one single payer and we're reducing the number of jobs in the private sector, we should make a plan, and we've provided for that. So any individual that's displaced from the health insurance industry would receive $60,000 per year for 2 years to transition either into a job in this new system or transition into a job somewhere else. So we want to make sure we're thinking about everybody through this process and we leave nobody behind. So the transition time period for this bill would be 2 years. And there would be a transition advocacy group that would be put together composed of experts, stakeholders, and regulators, as well as state and local elected officials to make sure that that planned transition happened effectively and efficiently. So I'll leave you with this. I think people in this country right now are sick and tired of being sick and tired of healthcare costs going up and up year after year after year after year, and they are. We know that with the big, beautiful bill passage that our health care is in a spot where we're going to see even larger increases over the next few years. And we're going to see people falling off the rolls. I'm talking to people on a weekly basis at this point that are afraid of losing their health care over the next 2 years. We're talking about creating a plan here. And you know what? I think that Ohio can even do it better than the feds can do it. I think we can put together a plan that takes care of our own folks at a reasonable cost. And this gives you a good template of a place to start to do that. So, Mr. Chair, I want to thank you again for your time, and we'll take your questions.
Thank you for your testimony. Any questions from the committee? You were first, Ranking Member. Ranking Member Hall? Ladies first. All righty then. Representative King.
Thank you, Chair, and thank you for your testimony and for being with us today. So immediately I've got some concerns and questions. I mean, the bill undermines private insurance and employer plans. Mm-hmm. And a universal plan. How would that dovetail with the federal requirements, and specifically with ERISA, which is going to be a very complex legal issue? So
Sure.
What's your thoughts on that?
So what this plan lays out is that any type of plan that's currently provided through the federal government, the state would be encouraged to go and seek waivers to basically see if we can fold those plans into this plan. That's CHIP, RISA, all the other different components. Medicaid, we know we spent $38 billion in the state on Medicaid. Could be rolled into this and then be one plan that, but if for some reason they couldn't, I could envision too Medicare Part A and B, which is a pretty robust plan. A lot of people like their Medicare A and B, would remain, and this, how it's written, would be then just a secondary insurance on top of that. So there are some challenges ahead, certainly, in implementation. That's why also we have a 2-year period to figure out those waivers so we could fold those plans in, and then make sure that the things we would want to keep as a state and that board would want to keep, we can keep, and this would then be a secondary option to make sure that all the things we want to cover are covered for the individuals, every resident of the state of Ohio.
Follow-up?
Thank you. You are aware about 71% of plans in the Midwest are covered by ERISA.
It's a big number.
Yep, okay. Thank you.
Thank you, Mr. Chair.
And now Ranking Member Hall.
Thank you, Chair. See, chivalry's not dead, Chair. So first, let me just, again, begin by thank you. So through the Chair to Rep. Rader and Rep. Graham, first off, thank you for coming today and bringing this testimony. Obviously, you know, I believe that healthcare is a right, not a privilege, and that we need to find a way to ensure that everybody has at least a basic humane level of healthcare. My question, though, would be, with regard to, can you unpack the structure just a bit as far as, 12 million people, in full disclosure, I've worked for health insurance companies in the past, so that's my disclosure. And I think about sort of things like the nuts and bolts, like third-party administration, building network adequacy. You referenced some of the negotiation piece as well. That takes a lot of people to do that. So So would you envision this sort of structurally rolling under Medicaid, and expanding that out, or would this be kind of a whole new sort of hiring process, or do you envision that we would subcontract out to existing payers to administer this program on behalf of the Ohio Healthcare Board?
Yeah, I think the board is given a lot of flexibility to determine that structure, as it should. What I would encourage folks to do, and I've been looking a lot at, just look right across the lake, about 50 miles. Right across from my house is Canada, the entire Ontario healthcare plan. They have a similar system where each province has their own single-payer insurance program. A little bit different. We could always change this too to include small premiums or things that would be more appropriate maybe for our state or for our political makeup or whatever it is. But I would have full faith that we could do something. I don't think the system we have now is working very well. You almost need a PhD to figure out how to keep your health care and how to move forward. I mean, I talk to people who have law degrees who have a very hard time working through the paperwork. So I think anything we can do to move towards a single-payer system that is going to be far less complex in the long term, even if it creates some challenges in the near term. And I really do respect the question, and also Representative King's question. There are some huge hurdles here that we'll have to face in terms of how you deal with the current system, the way it's set up. But again, other countries have done it. Canada's done it very well. People up there have a very high approval rating of their healthcare system. So anyway, thank you, Mr. Chair.
Yeah. So yeah, through the Chair, just one comment and one follow-up question. My comment would be, so for example, in the military, we have TRICARE, right? And the government does not have the infrastructure to even provide for the folks in the military. So they subcontract out with folks like Humana and United by region in the country, and they basically act as the sort of subcontractor for TRICARE. And it sort of segues into my question. As someone who has TRICARE, it's not always, I can't say it's always great, and I guess my question here is, just playing red team on this, how would you message this to people who have employer-sponsored health care and they really like it, and we're suggesting this kind of paradigm shift? How would you message, or what would you say to those folks?
Yeah, I think one of the biggest pushbacks I get is you don't want big government interfering with your health care. We don't want to have government care. We don't want government choosing who our doctors are, right? And I think we have to make a big distinction between what universal health care is and what we're thinking of a universal single payer system. So we're not talking about socializing the entire healthcare system. We're not talking about the government hiring doctors. We're not talking about doing something that is even layered upon what we have to create more complexity. We're talking about reducing complexity and going to one payer. And then you get to keep your doctor. The system, the clinics of the world will continue to get to operate the way they operate. So, and we've created this sort of third-party board that's more made of regional experts, local folks. So we're not talking about us as legislators directly overseeing, or even the governor directly overseeing this. We're talking about folks that are from these communities that are actually going to have eyes on, and people that know a hell of a lot more than I. You guys are the experts too. You've got a lot of insurance expertise here on this board, and I certainly appreciate, again, the questions. But I do believe we need to make bold steps in a new direction if we're going to achieve some of our goals here, and I do think people are fed up.
Okay.
Thank you.
Follow up? Any other questions from committee? Seeing none, thank you very much for your testimony this morning. That will conclude the first hearing of House Bill 289.